This video demonstrates the screening test to detect developmental dysplastic hip in newborns. Two tests are commonly performed. One Ortolani test and other is Barlow's maneuver. Both these clinical tests, Ortolani and Barlow's, are part of orthopedic examination protocol for the newborn to detect congenital deformities. In developed world, these tests are performed by the neonatologist, birth attendants, or medical officers on the duty. Babies with suspicion of the DDH on a screening test are advised orthopedic consultation in the next few days for further evaluation. These babies with positive Ortolani click or Barlow's maneuver are given abduction brace, public harness commonly. Confirmatory ultrasounds evaluation is performed within 2 weeks of the birth. The babies with evidence of the DDH on static and dynamic ultrasonography are continued on abduction brace till stable hip is achieved. Centers where ultrasound facility is not available, physicians rely on the clinical test, continue on abduction brace till hip stability is achieved. In this position, physicians rely on the radiographic assessments. Public harness is very easy to apply, maintain and taken care of the baby in harness. And ultrasound or examination can also be done within the harness. To demonstrate Ortolani click on the test model, Ortolani used it since 1948 and it is included in a screening program in developed world to reduce the dysplastic dislocated hips. Tests should be performed on each hip separately, one by one. Pelvis on the contralateral side is stabilized by thumb on the pubis while fingers on the sacrum. Hip tested to be flexed over 90 degree. Knee is flexed to maximum flexion. Then grasp knee and thigh in placing thumb near the lesser trochanter and fingers on the greater trochanter. Gently pull and abduct the thigh to the maximum abduction. Guide the femoral head towards the acetabulum by pushing the greater trochanter fingers while doing the abduction. The hip will remain reduced if dislocated with a click felt by testing hand. The fine click felt during the arc of abduction indicates Paedsortho Ortolani test. Barlow's test is used since 1964. Thumb and fingers are placed as in Ortolani test, but test is performed in the reverse order. In this maneuver, hip is manipulated to dislocate the dysplastic hip. Pelvis on contralateral side is stabilized by thumb on the pubis while fingers on the sacrum. Hip tested to be flexed to the 90 degree, knee is flexed to the maximum flexion, grasp the knee and thigh in placing the thumb near the greater trochanter and fingers are over the trochanter. Gently push knee towards the hip joint, adduct with gentle pressure by the thumb so that hip dislocates. Dysplastic hip may dislocate with a click felt by maneuver in hand. Relocate the hip with Ortolani maneuver. Repeat the test with Barlow's maneuver. Dislocation, relocation with this maneuver will indicate presence of the dysplastic dislocatable hip. Test is performed on the other side by same stabilization. When both hips are dislocatable, test should be performed on both sides simultaneously. While performing these tests, one should be very gentle and kind, otherwise he can miss the Ortolani click. One can master the technique by performing tests repeatedly on the test models especially made for this purpose. Following Ortolani and Barlow's maneuver, students are advised. This video demonstrates the principles and procedures of the Salter innominate osteotomy. Salter pelvic osteotomy is primarily indicated by DDH, which may be dislocatable or subluxatable. Osteotomy is indicated in age group 18 months to 6 years. Salter's osteotomy is indicated when hip is stable in flexion and abduction and dislocates in weight bearing position and adduction and extension. Dysplastic hip dislocates locations. The acetabulum faces more anteriorly than lateral, which is known as frontal inclination by Lang-Skjold. Acetabulum therefore remains deficient superiorly and anteriorly. Femoral head remains uncovered antero-superiorly in unstable hips. Salters designed the osteotomy to provide the cover to the uncovered head. Principle of Salter's osteotomy is based on the redirecting whole of the acetabulum with its three components: ilium, pubis and ischium as a one unit. Salter osteotomy is a transverse osteotomy from sciatic notch to the lesser inferior anterior spine. This osteotomy is transverse and perpendicular to the vertical axis of the ilium. Acetabulum is directed by combination of hinging and rotation on the pubis, which is quite mobile in young children. The concentric anatomical reduction of the hip joint without any pressure is the primary and prime prerequisite of the Salter osteotomy. Redirectional osteotomy has advantage on the other osteotomy, that is neither produce alteration in the shape of the acetabulum nor it decrease capacity nor it decrease the capacity of the pelvis like in the caries osteotomy or triple osteotomies which displace medially. Redirected acetabulum with concentric hip allows early weight bearing, good stability, and it provides an excellent stimulus which is called mutual growth stimulating effect for the development of hip components. Start. To perform Salter's osteotomy on saw bone models, stabilize the bone model as patient is positioned supine. Place the jiggly saw from lateral side of the sciatic notch towards the medial side with a artery forceps grafts again from the medial side. Put on the holders and direct the osteotomy from sciatic notch to the anterior iliac spine and complete the transverse osteotomy by moving the jiggly saw towards the anterior inferior spine. Once osteotomy is complete, take a wedge of the bone from anterior iliac spine. The depth of the wedge should be equal nearly to the space from anterior superior to inferior iliac spine, like this wedge. Hold the distal part of the osteotomy with acetabulum with a towel clip and stabilize proximal of the scoring system for post-operative this, but scoring system, and
It is designed to relieve the patient difficulties incurred on performing daily accustomed habit by the Eastern lifestyle. The reason was that none of the existing clinical scope to Muleke and Fergus and evaluate these functional practice in the Eastern lifestyle. These are the three lifestyles which commonly use: the squat crouch position, Palti is the cross leg position, and the Tashahhud where we do the namaz. These three positions are used for the scoring system. And these all three scoring systems are classified as type 1, 2 and 3 depending on the number of limitations in these positions, and along with the endurance discomfort rate, and then they are classified as a score. When every score is type 1, that is excellent. One of any part is 2, then is 2, and 2 system is 3, and this is the excellent score system. And this was one of our studies, the comparative study along with the Bhatti scoring system with the Meke scoring system, and parameters used were the time consuming compliance and the compatibility with the Eastern lifestyle. The parameters evaluated introduced were significantly compatible with the Eastern lifestyle compared to the clinical methods. The Reconstructive is real-time information regarding limitation of the performing daily custom city habits, less time consuming, more friendly, and it exhibits satisfactory compliance. Follow-up videos regarding aids, home provides bias-free remote re-evaluation for long-term record keeping. Thank you very much.